A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. for you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. Thank you for your strict adherence to the CPD regulations and your kind compliance. So today's topic is organ donation and deceased donors. The guest speaker for today's lecture is Dr. Rachini Withanage, consultant anesthetist with special training in transplant, anesthesia and critical care at the Transplant Unit, National Hospital of Sri Lanka. Over to you, madam.
Good morning. I'm Dr. Rachini Withanage, consultant anesthetist with special training in transplant anesthesia and critical care. Currently working at the Transplant Unit, National Hospital, Colombo. And first of all, I would like to thank you, the Society for Health Research and Innovation, for giving me this opportunity. Without wasting much time, we'll move to the topic. So I'll be talking on organ donation and deceased donors. As you all know, transplantation is the best and sometimes the only form of treatment for many patients with end-stage organ failure. For example, for a patient who is having end-stage kidney disease, as treatment options, you can offer peritoneal dialysis, hemodialysis, and kidney transplantation. So invariably, for these patients, kidney transplantation is the best modality of treatment. So if you take a patient who's having end-stage chronic kidney disease or acute chronic liver disease or acute liver failure, the only treatment option for these patients would be liver transplantation. So the transplantation per se prevents premature deaths in patients with end-stage organ failure, and it enhances the quality of life of these patients in many ways. So it will ultimately reduce the healthcare cost of a country. So this data I obtained from the Global Observatory Donation and Transplantation. So this graph demonstrates the total number of transplants, which include kidney, heart, lung, liver, pancreas, and small bowel, which took place in the world during 2000 to 2022. So as you can see, over the years, the number of transplants are gradually going up, and there's a small dip during 2022 to 2021. This is due to COVID pandemic, but again the numbers are catching up. And globally, in 2022, there had been more than 150,000 transplants happen. So this is again data from same source. This shows the total number of transplants which took place in Southeast Asia during 2000 to 2022. Again, as you can see, the numbers are gradually going up, and more than 15,000 transplants had been done in 2022. So, the burning issue related to organ transplantation is the global organ supply demand imbalance. So, there's a universal shortage of organs for transplantation. At any given time, organ demand is much higher than the organ supply. So this has led to increased morbidity and mortality of patients with end-stage organ failure and also poor quality of life. And this imbalance has increased the healthcare cost with much economical burden to developing countries like Sri Lanka. So let's dig a little bit into this problem. So this data is from Health Resources and Services Administration, published in October 2023. So this first graph demonstrates the number of patients on the transplant waiting list by each organ. So as you can see, most are the patients with end-stage kidney disease awaiting kidney transplant, and then the second number would be patients with liver disease. So if you go to this second graph, this shows the number of transplants performed in 2023 according to the organ. So if you compare these two graphs, you can clearly see there's a gross discrepancy between the number of patients who are awaiting transplant and the number of transplants we have offered during this year. So you can see the degree of imbalance between the supply and demand. And only a limited portion of patients with end-stage organ failure receive the option of transplant. Again, this is from the annual transplant activity report in UK from NHSBT, which shows the transplant activity during last 10 years. So this upper line shows the number of patients awaiting transplants, and this blue columns demonstrate number of deceased donors, and then this ash column demonstrates number of transplants done. So which include both live and deceased donors. So at any given time, always the number of transplants are much less in number compared to number of patients who are waiting transplant. So this is the main problem we face globally when we manage patients with end-stage organ failure. So even though we don't have exact data in Sri Lanka, we all know the problem is much worse here than in developed countries. So moving on to the type of donors, basically there are two types of organ donors, deceased donors and live donors. Deceased donors again can be divided into two categories. First is donors after neurological determination of death, simply we call brain death, DBD, or heart beating donors. Here we retrieve organs from a person who had suffered brain death, that is his brain is not functioning, but still his heart and circulation is intact. And then the second category is donors after circulatory determination of death, which we call cardiac death, DCD, or non-heart beating donors. Here, the donor had a cardiac arrest and his heart is not beating. And again, these DCD donors can be again divided into controlled and uncontrolled DCDs, which I'm not going to describe here. So what are the contraindications to organ donation? Basically, the only absolute contraindications are CJD and HIV associated illness. All the other factors like age, multi-organ failure, positive virology, malignancy, post-operative complications, or extended period of hypoxia falls into the relative contraindication category. So each donor must be assessed individually to decide the suitability for organ donation. And medical legal issues does not prevent organ donation. A few words about live donors. The concept of live donation comes into play because disease donation alone cannot fulfill the massive organ requirement in the world. And the other reason is in some countries, disease donation programs do not exist. So then the option would be only live donation. So in live donation, the transplantation becomes elective so that we can schedule the transplantation to a time that the patient needs transplantation. We can optimize the recipient well, and the live donors organs are considered as good quality organs than the deceased donor organs because we get the organs from healthy donors, and the cold and warm ischemia times would be less compared to deceased donors. So live donor transplants have a better outcome than deceased donor transplants. On the other hand, this opened the opportunity to commercialization and organ trafficking, which is very common in third world countries. And there's a health-related risk to donors as well as possible social and financial costs. So, disease donation is the process of giving an organ or part of an organ at the time of donor's death for the purpose of transplantation to another patient. So, in disease donation, we can retrieve multiple organs. Basically, we can retrieve 8 organs from one donor, that is 2 kidneys, 2 lungs, liver, heart, pancreas, and bowel. So, one cadaver donation can provide life support to 8 patients with end organ failure. And this will reduce the healthcare cost, and this is a good solution for organ supply and demand imbalance, and there would be no live donor risk. So, these graphs I obtained from the annual transplant activity in the UK, NHSBT, which shows the survival rates after first kidney transplant. So, the first graph shows long-term graft survival after first adult live donor kidney transplant. So, as you can see, the survival rate gradually decreases over the years, and this second graph shows the long-term survival rate after first DBD adult kidney transplant. So if you compare these two graphs, there's a slight reduction in survival rate in these DBD donors compared to live donors. And the third graph shows the long-term survival rates after first adult kidney DCD transplant, DCD donor transplant. So again, the survival rate is slightly less compared to DBD kidneys. So what I want to highlight here is, if you see, go through this graph, you can see there's a drop in survival rates, long-term survival rates in from living donation to DBD to DCD, but that drop is not very significant. So both DBD and DCD donors comparatively have a good outcome as live donation. So this is again data from same source, which shows the survival rates after first live donor, first DBD liver transplant and DCD liver transplant. Again, there's a reduction in survival rates in liver transplant, DCD liver transplant compared to DBD, but the drop is not that significant. So, as I mentioned earlier, this is we can retrieve multiple organs from deceased donors. When we talk about the quality of these organs, live donors organs have better quality than deceased donors, but still we can improve the quality of organs by proper donor management. So the early identification of potential donors become extremely important to maximize the number and quality of organs. And there are two fundamental ethical rules in deceased donor transplant policy. First one is DDR, that is deceased donor rule, we call, that is donors must be determined to be dead before their organs are removed. So basically we have to confirm either brain death or cardiac death, just because we can't retrieve organs from a living person. And the second rule is someone must have consented to the organ removal. So there should be a valid consent before proceeding to organ retrieval. These two graphs from Global Observatory Donation and Transplantation. The first shows total kidneys, number of total kidneys from living donors in the world from 2000 to 2022. So as you can see, the numbers are gradually going up. Again, there's a dip during the COVID pandemic. And the second graph shows total number of kidneys from deceased donors. Again, it's the number is gradually going up over the time. If we compare these two graphs, the number of kidneys from deceased organs is always higher than the live donor kidneys. So this is graph showing total number of living liver donors and total number of deceased liver donors. Again, the numbers are gradually going up over the time, and number of livers from deceased donors is always higher than live donation. Donation after neurological determination of death. Currently, most organs for transplantation are retrieved from brain death donors. And so it is the only reliable source for cardiac transplant. So because we can't retrieve a heart from a cardiac death person, or live donation is also not possible. And good quality organs, we can ensure the quality of organs by proper donor management and keeping the minimum warm ischemia time. And the diagnosis of brainstem death and declaration of death is one of the most important fundamental rules in donation after neurological determination of death, which I will be talking in a minute. So, for the diagnosis of brain death, there should be three essential components should be met. First one is fulfillment of essential preconditions. So I will describe it. And second one is exclusion of potentially reversible contributions to a state of apneic coma, and the formal demonstration of coma, apnea, and the absence of brainstem reflex activity. These tests should be carried out by two qualified doctors who are competent with the procedure, and one of them should be a consultant, and both should have been fully registered with the Medical Council of the country for at least 5 years. and the test must be undertaken by two doctors together and completed successfully on 2 occasions. And any one of these doctors should not be from the transplant team. These are the preconditions. The patient should be deeply unconscious, apneic, and mechanically ventilated. And there should be no doubt that the patient has suffered irreversible brain damage of known etiology. For example, spontaneous intracranial hemorrhage, hypoxic brain injury, ischemic stroke, or trauma. And in some rare occasions where the primary diagnosis remains obscure, an extended period of clinical observation and support may be required before the irreversible nature of the pathology can be confirmed. So these are the preconditions that should be fulfilled. Patient should not be hypothermic. Temperature should be more than, core temperature should be more than 35 degrees of Celsius, because hypothermia can cause impaired consciousness and brainstem areflexia. And biochemically, the electrolyte should be within these ranges. And sometimes brainstem death per se can cause electrolyte imbalances, such as hypernatremia and diabetes insipidus, which should be kept in mind. And the blood glucose level should be between 55 to 360 milligrams per deciliter. And pH should be normal, that is between 7.35 to 7.45. And PaCO2 should be less than 45 millimeters mercury, and PaO2 should be more than 75 millimeters mercury, and any endocrine disturbances should be excluded from the history. Patients should not be on any sedatives, and adequate time should be allowed for excretion or metabolism of sedatives at the time of diagnosis. So the observation period should be more than 4 times the T-half of the drugs. And we can also administer specific antagonists if we suspect residual effects overdose. For example, benzodiazepines overdose, we can suspect flumazenil. If we suspect opioids, then we can give naloxone. And we can perform plasma analysis to make sure that the drug levels are not detected or at subtherapeutic level. Particularly, this plasma analysis is particularly done for drugs with long or unpredictable half-life, like thiopental or phenobarbital. And despite this above guidance, if the effect of sedative drugs can be dismissed if there is independent evidence brainstem death on basis of CT or prolonged malignant intracranial hypertension. That means the Academy of Medical Royal Colleges allow us to diagnose brainstem death with demonstration of absence of cerebral blood flow with CT angiography if we cannot exclude the effect of sedatives and depression drugs. And these are the reversible causes of apnea which should be excluded, that is severe neuromuscular weakness, cervical spinal injury causing respiratory paralysis, and residual drug-related neuromuscular blockage. So we can use neuromuscular monitoring to exclude these things. And then the brainstem reflexes should be performed. There are 6 tests which should be done, and I'm not going to describe each of these. And there are all reflexes should be negative. If any one of these is positive, we cannot diagnose the brainstem death. And then the apnea test should be performed when the absence of brainstem reflexes has been confirmed. The aim is to provide an acidic respiratory stimulus, that is pH of less than 7.4, without inducing hypoxia or cardiovascular instability. So first we increase FiO to 1, and then we do ABG to calibrate saturation and EtCO2. Then the minute ventilation should be reduced until EtCO2 is 45 and pH is 7.4, and the saturation should be remain more than 95%. And then the apneic oxygenation, we can maintain the apneic oxygenation by either by disconnecting from the ventilator and instilling oxygen into lungs via a suction catheter in a rate of 5 liters per minute, or we can simply switch to the CPAP mode of the ventilator. Then any respiratory activity should be observed for 10 to 15 minutes. If the patient is having any respiratory activity, we cannot diagnose the brainstem death. And the other factor is we have to confirm there's an increase of PaO2 more than 60 or more than 20 millimeters mercury from the baseline to make sure that there's an acidic stimulation for respiratory stimulation. But keep in mind, in patients with history of chronic respiratory diseases, this PaO2 targets may be higher than these values. And after completion of the test, ventilator should be reconnected and acid-base status should be normalized before the second set of tests. And if the systolic blood pressure drops less than 90 or patient desaturates, or if any cardiac arrhythmias occurs during this test test should be stopped and patient should be reconnected to the ventilator. So there are situations where the clinicians are unable to confirm brain death based on the clinical assessment we described above alone. So, for example, when we can't perform the comprehensive neurological examination, instances such as severe facial injury, and when the influence of residual sedation cannot be excluded, and when high cervical cord injury is suspected, where we cannot distinguish between the central apnea and the effect of cervical cord injury. So in these circumstances, we can use this ancillary test aiming at confirming the presence or absence of cerebral blood flow or cerebral function. So cerebral blood flow or cerebral perfusion can be detected in CT angiography, and EEG can be used to demonstrate any cerebral function. But EEG is of little value in case of drug intoxication. So little bit about the pathophysiology of brain death. So when the cerebral injury occurs, there would be either cerebral edema or intracranial hemorrhages, which will increase the volume of components inside the skull. And then according to the Monro-Kelly doctrine, then the intracranial pressures goes up, causing the mass effect, and then the herniation of brainstem will take place, causing medullary ischemia and other widespread derangements in the body. So if we take the cardiovascular changes, initially with the increase in ICP, there would be a compensatory hypertension to maintain cerebral perfusion with reflex bradycardia, which we call Cushing's reflex. And then this is followed by intense catecholamine release, which we call catecholamine storm, due to brainstem herniation and medullary ischemia. So this will cause intense vasoconstriction and central distribution of blood, tachycardia and arrhythmias. So this in explosive increase in ICP, it has demonstrated that there is more than 100% fold increase in circulatory epinephrine concentration. So during this period, there would be increased afterload due to vasoconstriction, and there would be increased contractility and tachycardia, arrhythmias, which can invariably cause myocardial injury. So the myocardial incidence of myocardial injury is common as in DBD is around 20 to 25%. So it's common. And this the severity of these changes depends on the speed of onset of brain death. The more rapid increase in ICP will cause more severe changes. And also, this intense vasoconstriction can cause visceral ischemia. These changes are then followed by loss of sympathetic tone, profound vasodilatation, and hypotension. And if untreated, this will ultimately result in donor loss. So we have to understand these pathophysiological changes to offer a better management for the DBD donors. And respiratory changes wise, due to this sympathetic storm, the pulmonary capillary hydrostatic pressure is increased, and along with that, the circulatory epinephrine will cause capillary endothelial damage. Both will cause pulmonary edema. And myocardial injury, if there's myocardial injury and ventricular failure, that will also be added to the causes of pulmonary edema. And patient can also have aspiration pneumonia commonly. These patients will invariably develop hypothermia due to hypothalamic damage or reduced metabolic rate, vasodilatation, and heat loss. And the diabetic insipidus is common due to posterior pituitary damage, which will lead to fluid and electrolyte imbalances. And there would be reduced insulin and insulin resistance, which will cause hyperglycemia. And patient can have disseminated intravascular coagulation due to release of tissue thromboplastin from necrotic brain. And there's an active inflammatory response which happens in brainstem death, and also added with inflammatory response to pre-existing injuries. So those are the endocrine, metabolic, and stress responses in DBD donors. So, talking about the management goals of brainstem donors, ideally these patients should be always managed in critical care settings. And with the diagnosis of brainstem death, our management goals changes. So before the diagnosis of brain death, our management is to maximize the chances of patient survival. But after diagnosis of brain death, if donation is a possibility, then our aim would be to maintain their organ systems to ensure the great number of organs suitable for transplant. Still, despite this standard active care, the incidence of donor loss before retrieval would be about 25%. So these are the physiological goals of donor management. Patient should have minimum invasive cardiovascular monitoring, that is invasive blood pressure and CVP, and cardiac output monitoring can be considered if indicated, such as if we expect to retrieve the heart, then cardiac output monitoring would be useful. And then the patient's heart rate should be maintained between 60 to 120. Systolic blood pressure should be more than 100, and MAP should be equal or more than 70, and CVP should be maintained between 6 to 10, and fluid therapy should be goal directed. The urine output should be maintained between 0.5 to 3 ml per kg per hour, and normal potassium, calcium, magnesium, phosphate should be maintained, and serum sodium value should be maintained between 130 to 150. This is very important if we are planning to retrieve the liver. And blood glucose level should be between 70 to 145 milligrams per deciliter. And pH should be normal, that is between 7.35 to 7.45. PaCO2 should be between 35 to 45 millimeters mercury, and PaO2 should be more than 8 millimeters mercury. And the saturation should be equal to more than 95%. And any unnecessary drugs should be stopped. And as I mentioned earlier, patient will invariably develop hypothermia. So heat loss should be prevented, active warming should be started, and lung protective ventilation is important. And all the measures should be taken to reduce aspiration. And if the patient is having any infections, they should be treated. And patient should be given methylprednisolone 15 ml per kg dose. And if the patient is having any active bleeding, coagulation should be corrected. So that is about the brainstem death donors. Moving on to the donation after circulatory death. This refers to organ donation taking place once circulatory arrest has occurred following treatment withdrawal. So here, we allow the patients to have a cardiac arrest and confirm death, then we retrieve organs. So there's a time period between cardiac arrest and organ retrieval, which we call warm ischemia time, which is more prolonged than DBD donors. So when we compare DBD organs and DCD organs, the quality of organs is better in DBD than to DCD. So these are the preconditions. Organs are retrieved from patients where we decide treatment is futile, so we decide to withdraw the life-sustaining treatment. For example, severe irreversible brain injury where the brainstem death is not diagnosed or not possible to diagnose, severe cardiac or respiratory failure, or ventilator-dependent quadriplegia. And the second precondition is death should be likely to occur within within 60 to 90 minutes following the treatment withdrawal. This is because if this death doesn't occur during this time, the warm ischemia time would be much greater, and organs are not suitable for transplantation. So then this time should be less than 60 to 90 minutes. And then third one is there should be no contraindications for organ donation. So in the process of donation after circulatory death, there should be a good communication with transplant team, because we have to organize the timing of treatment withdrawal and retrieval to make sure we get the good quality organs. And consent issued should be sorted, and documentation should be clear, including reasons for treatment withdrawal, and patient the anxiolytics and analgesics should be administered until the moment of death to make sure the patient is comfort. And treatment withdrawal can take place in the ICU or operating theater. What we usually do is either extubate the patient or just switch off the ventilator. If we have extubated the patient, we might need to reintubate to prevent aspiration to permit diagnosis of circulatory death. So the diagnosis of circulatory death is diagnosed after 5 minutes of continuous asystole. So asystole is defined as absence of myocardial absence of mechanical cardiac function. So this can be identified by continuous ECG monitoring, intra-arterial pressure monitoring, or echocardiography can also be used if there's a competent person. And if there's during the period of observation for cardiac activity, if there's any return of cardiac or respiratory activity, further 5 minutes of observation should be done. And after completion of 5 minutes continuous asystole, clinician should confirm the absence of pupillary reaction and motor response to corneal stimulation and supraorbital pressure. So this diagram I obtained from the annual transplant activity in the UK from NHBT. So this shows the UK potential deceased donor population during April 2022 to March 2023. So if you look at this first line, this is UK population during this year, and then there had been deaths, 666,000 deaths during that period. Out of these deaths, 290,000 deaths has taken place in hospital. So these are the these are the possible organ donors. From if the death occurs in the hospital, yes, there's a chance of retrieving organs from these patients. And then out of this death, only 6,763 are potential donors suitable potential donors. And if you see this last one, the actual donors, that is number is 1,429. So this actual donors means the donors which proceed to retrieval. So you can imagine only a very little portion reach this last stage. So what happened to the rest? So there's donor loss due to various reasons at many stages. So this is another main issue with deceased organ donor programs. Most of the reasons for this donor loss can be avoided to maximize the number of organs we retrieve from deceased donors. And how we can avoid these donor losses? It is mainly the responsibility of the healthcare staff. It's our responsibility to maximize deceased donors and maximize deceased donor organ retrieval. So this is my take-home message. So there are more than 100,000 men, women, and children on the national transplant waiting list globally. Every 10 minutes, another person is added to the transplant waiting list, which shows the gravity of the problem. And 17 people die each day waiting for an organ transplant. So every donor can save 8 lives and enhance over 75 more. So we can help both the donors and healthcare staff. And it is our responsibility to initiate this program and maximize the number of deceased donors. So we should make it possible, and we should support the gift of life. So live beyond life. So that is my take-home message, and these are my references. So if you have any questions, please kindly send an email. Thank you.
Thank you very much, madam. So, dear participants, if you have any specific questions, you can email madam, or you can email us on officeshri13@gmail.com. So again, our sincere thanks to Dr. Rachini Withanage, consultant anesthetist with special training in transplant anesthesia and critical care at the Transplant Unit, National Hospital of Sri Lanka. And let's conclude today's session. So please fill the link in the chat box and kindly give your feedback, and then you can receive your e-certificate for participation. Thank you very much.